muscular dystrophy therapy and management. Innumerable therapeutic trials of variety of drugs have been undertaken, but in none has there been any convincing evidence of lasting benefit. Therefore, in the present state of our knowledge, management of Duchenne muscular dystrophy must start with the realization that there is no specific treatment of this disorder. Mobility is a major problem in the early years after diagnosis is made. From the early phases of the disease, there is a tendency towards walking on the toes. It is arguable why this should or should not be. An inequality in weakness between the below knee anterior muscles and posterior muscles may be the explanation. On the other hand, the pelvic girdle weakness will allow some rotation forward of the pelvis, and in order to maintain the center of gravity within the axis of body, lordosis, slight flexion at the knees, and extension of the ankles is necessary. Contractures at the hip and ankle are common findings in the ambulant boy, but this does not resolve what could be considered as a chicken and egg argument. The role of physiotherapy in the management of Duchenne muscular dystrophy has to be reviewed realistically. There is no evidence that exercise programs have any benefit, although regular moderate exercise is as desirable as it is to any individual. Immobility, for whatever reason, poses real threats to the child with a neuromuscular disorder. A period of inactivity may be followed by a profound decrease in mobility which may or may not be irreversible. Thus, a boy with Duchenne muscular dystrophy should be mobilized at the very earliest opportunity after any illness or operation. Joint contractures, hip and ankle may be delayed, although not entirely prevented by regular passive stretching. Parents may be instructed in how stretching of the tendo Achilles can be accomplished by a regular routine of dorsiflexion of the foot with the knee and flexion with the knee flexion and extension. This can be incorporated into a bedtime routine but must never be allowed to become a major issue so that rebellion on the part of the child may make the whole procedure somewhat fraught. The management of incipient hip contractures should be with the encouragement of the boy to spend time each day lying prone with the chest and body extended, preferably over a wedge. Typical posture of a boy with Duchenne muscular dystrophy figure. Orthopedic intervention in the ambulatory phase of Duchenne muscular dystrophy presents a difficult decision. While it still remains debatable as to why boys with Duchenne muscular dystrophy walk on their toes, a logical approach and a question as to the desirability of elongating the tender Achilles must inevitably exist. In many boys, the toe walking appears necessary for ambulation, but in others, it is without reasonable doubt part of their locomotor handicap. In the author's experience, elongation of the tender Achilles, whether performed as a subcutaneous tenotomy under local anesthetic or as a more definitive procedure, has done little to improve ambulation. Nevertheless, some have argued that elongation of the tender Achilles combined with release of possible structures at the knee and of the iliotibial tract and the fitting of calipers has improved and maintained locomotor function in those who were in danger of going off their feet. Considerable controversy surrounds the fitting of calipers to boys with Duchenne muscular dystrophy. It can be argued that well-fitting lightweight calipers in a boy with no joint contractures can aid locomotion, but it can be argued so that the benefits are very short-lived. Many boys, by the time they are experiencing major locomotor difficulties, are only too anxious to acquire true mobility, and the only way this is possible is with a wheelchair. Nevertheless, the fitting of calipers must be considered in any boy whose locomotor function has deteriorated to the point that continued ambulation is in question. The considering in considering this, there must be involvement of the orthopedic surgeon pediatric physician, physiotherapist, orthotist, parents, and the patient. From the time of diagnosis, not only it is vital to emphasize the desirability of regular but not excessive exercise, the avoidance of immobility for whatever reason, but also the prevention of obesity and the development of interests that do not depend upon physical well being. When it is clear that ambulation is no longer practical or reasonable, the management of the boy with muscular dystrophy in a wheelchair has to be considered. Using a wheelchair for both the boy and his parents, the acquisition of wheelchair and the dependence upon it represents a major milestone in the course of the illness. In effect, going off the feet is not usually a sudden process, as very often it has been found necessary to use a wheelchair for certain activities such as shopping or generally getting about outside the house, perhaps following an illness or an operation. Life in a wheelchair brings it with it certain problems. Contractures Contractures rapidly develop at the hip and knee, and they are virtually impossible to prevent. Ankle contractures are often present by the time a boy goes into a wheelchair. Elongation of the tender Achilles is indicated in all boys as the progressive development of talipus equinus varus will make shoe fitting difficult, if not in some impossible. This is a procedure that can be undertaken under local anesthetic and should be followed by splinting with either plaster of Paris, Bologna iron calipers, or a molded splint for at least a few months after surgery. Many support wearing of night splints following surgery. Severe talipus equinus varus not only produces problems with shoe fitting but also positioning in bed and transferring from chair to toilet, chair or bed. Scoliosis. One of the major problems for the boy with severe muscular dystrophy using a wheelchair is the development of scoliosis. There is no doubt that this is a problem that develops only after going into a wheelchair, although scoliosis is described in some boys with muscular dystrophy who are still ambulant. Quite why some boys develop a scoliosis after becoming immobile and others do not is not really understood. Observations have been made that if there is a significant lordosis, the intervertebral facets are locked and thus the spine is fixed. This observation has led to developing one form of spinal bracing that attempts to produce such locking. Severe scoliosis will lead not only into major postural difficulties but also to reveal respiratory difficulties, in themselves life threatening. A careful watch must be kept on the possible development of scoliosis, and when seen, early bracing is essential. Often it is difficult to persuade the boys and their parents that bracing is necessary, and together with this, it may be that the spinal braces are too restrictive for adequate respiratory function. Gibson in Toronto has described what appears to be an effective brace that is neither significantly restrictive to the chest nor uncomfortable to wear. The problem of scoliosis raises a major question, that of wheelchair design and fitting. If scoliosis is first considered, it has been suggested that if a wheelchair has a 10 to 15-degree back slope, the scoliosis may well be prevented or delayed in developing. On the other hand, it is hardly functional to be in a chair which one is sitting well back, and most boys prefer to lean forward and lean on one or other arm of the chair. Soft wedges placed inside the chair on either side of the trunk help in giving support. The prevention of foot deformities depends to a great degree on the resting position of the feet while in the wheelchair. It is therefore vital that the foot plates on the wheelchair are correctly adjusted. Wedges placed between the side of the chair and thighs help to keep the knees from flopping outwards. As referred to above, an electric chair is needed very soon after ambulation is lost, as upper limb weakness by then becomes very significant. The control system of the chair will be suited on one or other arm of the chair. Studies have been undertaken as to whether posture may be improved in the chair if the control is in the center. So far, there is little to suggest that a centrally situated control confers any definite advantage. The cause of death in Duchenne muscular dystrophy is virtually always from respiratory infection. At times, this may be combined with cardiac failure because of cardiomyopathy. Breathing exercises are desirable for all boys and should be instituted at the very latest at the stage of going into a wheelchair. Together with this, active treatment with antibiotics and physiotherapy for any chest infection is essential. Social problem. There can be a few conditions that pose such strains on parents, therapists, teachers, doctors, and patients. As Duchenne muscular dystrophy, from time of diagnosis to the time of death, both patient and parents need a great deal of support. Diagnosis brings with it a major trauma to any family. While the temptation may exist to spare the parents the full details of the disease, it is the opinion of the authors that they should be told everything from initial diagnosis. Following the initial telling, full support and the willingness to talk through all the implications of the diagnosis must be offered. The involvement and support of an informed social worker can be invaluable. As time passes, true realization of the extent of the handicap will dawn on the family. This thus support is a continuous need. The time of diagnosis is the first crisis in the life of the family. Invariably, the next crisis comes when the boy finally and completely takes to a wheelchair. The degree of the dependency then becomes very great. Assistance is needed for dressing, toileting, turning in bed, and later for feeding. As the natural history of this disease is well known and reasonably consistent, the problems associated with dependence should be anticipated. Where necessary, applications for adaptation to the home should be made well in advance of the stage of motor dependence, and an occupational therapist should undertake a careful, comprehensive review of the aids that will be needed within the home. School placement depends partly upon the wishes of the parents, the attitude of the staff at the ordinary school, and the architecture of the school. There are certainly advantages in a physically handicapped school in that it is likely that it will be on a single level and relevant therapy staff are available. On the other hand, the educational standard at many physical handicapped schools may be lower than that of an ordinary school. The strain on families who have a boy with severe muscular dystrophy is immense, and as stated above, support is essential. Parent groups can be very useful. Marital breakup is frequent. The mother so often being left to cope with the physical and emotional demands a totally dependent adolescent. If the physical demands are not enough, there is need also to recognize that, in spite of a progressive physical disease, the emotions of a young teenager remain throughout. Some years ago, one of us was moved when told by a 16-year-old boy with muscular dystrophy that what he most wanted to do was to drink beer and chase women. He could do neither.